In today's session. So today this is 22nd session of NOEL of the 4th edition. And as we are aware, in each session, we discuss a case presentation, and few of the occasions we go for the faculty speaker. They deliver some lectures, guest lectures. But today's session is a case presentation, and to present this interesting case with the challenging respiratory difficult airway case or respiratory case, I will say overall. Dr. Archana Dinraj, he is an NF fellow from KIMS Health. I thank the KIMS Health team, Dr. Femita, who is going to the faculty of KIMS Trivandrum, who is going to moderate the session, and Dr. Naveen Jain sir also, who facilitated this presentation to start the presentation. And we are fortunate enough today we got two of the eminent, along with the moderator, who's Dr. Femita. She is a well-known academician, and in the neonatology field, everybody knows her. During the conference or the many of the publications, she is very active academician. And another two eminent faculties, we got Dr. Naveen Bajaj sir, and he is the director of neonatology from Ludhiana, Punjab. Sapling Hospital. He's the director and director of neonatology. And everybody in IIP NeoChaf and NNF is a quite senior faculty and contributing to the academics since so many years. So everybody knows, no need of any specific introduction. And along with that, Dr. Tushar Parikh, who is a faculty in KM Pune, who is a training institute for the DM student and DNB student. And along with that is faculty chief neonatologist in motherhood in the Pune. So with these two eminent faculties inputs, we are going to learn few of the clinical management tips today and how to approach a case of difficult airway. With this, I will request Dr. Archana to go ahead with the presentation, and I will request all the participants to, in the meantime, to ask any of the questions to put in chat box. So end of the session, we will try to take those questions and clarify with this the faculty's inputs, and this, we all will try to clarify whatever the learning points from here. So request Dr. Famita to lead the session today, to moderate the session, lead the session, and Dr. Archana you can start the session presentation so that we can further discussion. In the meantime, it is not like a didactic teaching. In between, probably I will request both the faculties and moderator to interrupt and ask and add values to the presentation throughout the session. Thank you all. Please, Dr. Archana, you can go ahead with the session today.
Okay, sir. Good evening. Good evening. I'm Dr. Archana. I'm presenting the case of a 21 days old female newborn, X, born by elective LSCS at term gestation with a birth weight of 2.53 kg. Baby was brought to our NICU for respiratory distress and difficulty in maintaining airway. Coming to mother details, she is a 32-year-old G2P1L1. It was a non-consanguineous marriage and her blood group is A positive. Her first pregnancy was 6 years back.
I was trying to clarify the previous slide.
Sir.
Baby was brought to NICU for respiratory distress is fine and difficulty in maintaining airways. What is meant by this? Difficulty in maintaining airways.
Sir, this baby had some anatomical abnormality, including micrognathia and retrognathia with glossotosis. And so baby was not maintaining saturation in supine position. We had to resuscitate the baby in lateral position. So there was a difficulty in maintaining airway.
Please carry on. Go ahead.
Okay. Antenatal history. There was no history of any bleeding or leaking per vagina. She had gestation diabetes mellitus. It was well controlled on OHA. Antenatal ultrasounds at 12 and 20 weeks were normal. Fetal echo was normal. There was no history of polyhydramnios. Ultrasound scan at third trimester showed retromicrognathia. They were offered genetic evaluation, but it was deferred by the family. And Doppler evaluation was normal.
Why specifically you have written polyhydramnios?
Sir, in this specific case, the baby had associated cleft palate also. So there can be polyhydramnios, and if it is associated with any syndromes, there can also be polyhydramnios.
Can there be oligohydramnios?
It can be, there can be oligohydramnios also, sir. It may be a contributing factor to this retromycnonathia.
So isn't it a better idea to write amniotic fluid? There is no poly or oligohydramnios means the amniotic fluid is normal.
Okay, sir. Coming to natal history, baby was born by elective LSCS for previous years at 38 weeks of gestation on 19/6/2024 at 11:38 a.m. Baby's birth weight was 2.53 kg. Baby had weak cry at birth with poor respiratory efforts and cyanosis. Baby was noted retromicronathia and cleft palate. Positive pressure ventilation was given in lateral position. Baby was shifted to NICU with TPS resuscitator in lateral position. Coming to postnatal course in NICU, the baby was admitted in NICU with respiratory distress and Downey score was 4 and CPAP was initiated in lateral position with the FiO2 of 30 and PEEP of 6. Baby was started on OG feeds. Baby gradually improved and by day 3, we could wean to room air and we inserted a nasopharyngeal airway. Relevant consultations including cardiology, ophthalmology, genetics and plastic surgery consultation was done. We attempted bottle feeding and direct breastfeeding with some success. And baby showed gradual improvement with nasopharyngeal airway. By day 8, baby showed worsening of this respiratory distress and oxygen demand, cough and oronasal secretions. This time mother had upper respiratory tract infection. Baby was isolated and started on HFNC support with FiO2 of 30 to 35%. Baby needed frequent suctioning in view of profuse secretions, oral and nasal secretions. Baby was started on empirical antibiotics. Blood culture and sensitivity was done. The culture report came as sterile and we stopped antibiotic after 2 days. Filmare respiratory panel showed rhinovirus. The baby was managed symptomatically. And by day 12, baby improved and HFNC trialed off to room air. Present status of the baby. Now the baby is 21 days old and is recovering from upper respiratory infection. There is occasional cough and pooling of secretions. Baby is active and demanding for feeds. Problems are baby has a feeding difficulty needing OG feeds and partial oral feeds and non-maintainable airway requiring nasopharyngeal airway. The tolerance to supine position is better than at birth.
What about any dysmorphism? Like, did you mention any dysmorphism along with that, and any effect of crying? Basically, whether it relieves, whether the distress is more during crying or at resting stage.
There was no difference when the baby was crying, sir. It was not relieved with crying. It was not observed, sir. And there were no obvious dysmorphism other than this retromicronathia and cleft palate.
Okay.
Coming to examination part, the baby is nursed in a bassinet. Baby is not on any warmer care. Continuous monitoring of heart rate and SpO2 is there. And baby is nursed in lateral position with a nasopharyngeal airway and OG tube in situ. OG tube is fixed at 20. The baby is comfortable with this nasopharyngeal airway and OG tube. It was 37.5 degrees Celsius and the pulse rate is 160 per minute.
Dr.
Dr.
Archana,
Archana's slides seem to be stuck.
your
She's just
connection
sorting it out,
is
sir.
somewhat troubling.
Naveen sir, you're muted, I think, sir.
No, I am not.
No, we
Share
can hear.
screen has also got lost. She's coming back on, sir.
Yeah, sure, no problem. Archana, can you hear us?
Dr. Archana, probably you're muted. Your slides we can see, but we can't hear you.
Oops.
Hello.
Yeah, now we can
Archana,
hear
you
you.
can go to the previous slides. There was a lot of disconnection in between. So you can go to the first examination slide.
Okay, sir. Hello.
Yes, yes. Yeah.
Sir, I will start from the vitals.
Yes.
The measured temperature was 36.5 degrees Celsius in axilla, and the pulse rate was 160 per minute. The pulse volume was good.
What is it okay for you if we ask along with the relevant questions are asked along with it? Why you have measured temperature in this baby?
Sir, this baby had a respiratory infection also, so temperature is important, sir.
Yeah.
Pulse rate is 160 per minute, but it is it is regular. Pulse volume is good, and peripheral pulses were palpable. Bilateral femorals were normally felt. BP is 80/52 with mean BP of 60 millimeter of mercury in right upper limb. Respiratory rate was
So
64.
what is the importance of measuring BP?
Sir, if it is associated with any cardiac anomalies, BP will be important, sir.
Important in what sense? Which cardiac anomalies has what sort of correlation with the blood pressures?
Sir, if it is associated with any
So blood pressure could be hypotensive or hypertensive in both ways.
there can be associated coefficient of iota or any association which can cause upper limb, lower limb BP difference, sir.
So this BP is measured where?
Right upper limb, sir.
Anything else? In this particular case, the relation of blood pressure.
Sir, if there is sepsis with myocarditis, it can cause hypotension and shock, sir.
Can there be hypertension in such babies?
Sir?
Can there be hypertension, increase in the blood pressure in such babies?
Hypertension,
Okay, you can go ahead. Yeah.
Respiratory rate is
Sir, you could help us with the answer also, sir, if it was BPD or chronic lung disease that could cause hypertension, it might help us.
Yeah, sometimes you'll have hypertension. Especially if there is CO2 retention, you'll have a reflection as hypertension to begin with.
Is that the answer you wanted, Naveen sir, or was there anything else that we should have considered?
No, the Tushar is correct. That is probably to start with. Then we are coming to the next other parameters.
Next part, yeah.
Baby is pink in color with CFT of less than 2 seconds. Saturation was 96% in room air and right upper limb. Coming to growth parameters, baby's weight at birth was 2.53 kg and present weight is 2.62 kg. Baby has crossed birth weight and it is in the 3rd centile in WHO growth chart. Length is 50 centimeter and OFC is 34 centimeter, both coming in the 50th centile. Coming to general examination, this is our baby. Anterior and posterior frontal are normal. Nice, there is no cataract or coloboma. Nose, we can see a nasopharyngeal airways in situ. In the left nostril, there is no nasal injuries. Baby has micro-retrognathia. Baby also has a cleft palate. Of the soft palate, there is no cleft lip association. In skin, there is no pallor, icterus, or any neurocutaneous markers. No skin or nasal injuries due to intensive care. Umbilicus, genitalia, anal orifice, and limbs are normal.
Yeah. Cleft palate, you want to be more elaborate? You're going to say it here, is it?
Sir, yes, sir.
Yeah.
This picture was taken on day 1. This baby has a cleft in the soft palate. It is actually a U-shaped cleft. It is difficult to visualize in this photo, but because of this, it was difficult to visualize because of the anomaly of the mandible. But there was a posterior cleft. And this in this picture, nasopharyngeal airway is in situ, and baby is comfortable with this nasopharyngeal airway. And OG2B is also in situ. Coming to the systemic examination, respiratory system, baby is in room air, mild tachypnea is there, respiratory rate is 64 per minute, no retractions, saturation is 97% in right upper limb, and air entry is bilaterally equal, and on auscultation, conducted sounds are heard bilaterally. Other system examinations, CVS, no visible precordial pulsations, S1, S2 are heard normally, no murmur. CNS, baby is alert and cries to stimuli of normal pitch. It's consolable cry. Tone is normal, activity is good, and quantity and quality of movements is normal. GIT, abdomen is soft, no hepatosplenomegaly, hernial orifices and umbilicus are normal. Summary, this is a term 38 weeks, age 2.53 kg baby with Pierre Robin sequence and cleft palate. Baby has a resolving respiratory infection.
So when you talk about Pierre-Robin syndrome sequelae, what do you mean by Pierre-Robin sequelae?
Sir, it is characterized by a triad of micrognathia, glossoptosis, and resultant airway obstruction.
Airway obstruction or cleft palate, is it part of Pierre-Robin sequelae or not?
Cleft palate is associated in about 90% of cases, but it is not included in the triad of Pierre-Robin sequence, sir.
Okay. And what are the certain anomalies of airway that are associated?
Pierre-Robin can have micrognathia, retrognathia, cleft palate, glossoptosis, that is tongue falling backwards and obstructing the upper airway.
Okay.
Archana, you knew this beforehand, before the delivery, that this baby is going to have issues with the airways. Correct if I have that the antenatal diagnosis, in the antenatal diagnosis, it was picked up.
Yes, sir.
So once you have an antenatal diagnosis and you know that this sort of baby is going to come up, any specific precautions you took at the point of attending this baby's delivery?
Sir, this type of cases where antenatally the risk is anticipated. So we have to plan the time of delivery and the place of delivery according to obstetric indications. And we should be prepared to persons knowing NRP with and advanced airway, NRP with advanced airway resuscitation should be available, and equipments for difficult airway also should be available. Like nasopharyngeal airway. We should add other persons with expertise like pediatric ENT, pediatric anesthesia also, sir.
No, just for the fellows who are also attending your session. So what are the preparation you have? What is the specific preparation you have done? Leaving aside the routine preparation which we all do for attending a delivery of the baby.
Sir, we did an antenatal counseling also, and we prepared a resuscitation tray which contains all the necessary equipments for difficult airway. And
what are those equipments we are saying difficult airways? What are the equipments? How do you define a difficult airway first? that this is going to be difficult, possibly a difficult airway. One. Second is, what are the specific equipments you are going to have with you when you attend that delivery? So not only equipment for difficult airways, but what sort of equipment which you would like to have, which everyone, all other fellows who are listening should have when they prepare themselves for such deliveries.
Sir, when a difficult intubation is anticipated, LMA should be available, sir.
What else should be there?
Sir, other than that, for critical suspected upper airway obstruction, we can have this nasopharyngeal or oropharyngeal airway and video laryngoscope if available, sir.
So that is possibly the first step, is the having a proper sized airway available along with you, which is commonly the oral airway. Because the nasal airway, so you can make immediately the oral airways. And second, you correctly said that the preparation for a intubation, which should include a video laryngoscope along with. And
Um,
you have said that you have put this baby on CPAP right in the delivery room, correct? If I am.
Yes, sir.
So what was the indication of giving CPAP in this baby in the delivery room? And if you have given a CPAP, what were the challenges you have faced in this particular baby?
This baby had respiratory distress, sir. In addition to this difficult airway, this baby was having respiratory distress also. So, and oxygen and cyanosis also needing oxygen. So, when we shifted to NICU, we kept the baby on nasal CPAP, which had an effect of splinting the airway also.
So what
And
are the challenges in these babies have while you give a CPAP? What are the challenges you have faced in this baby? Have you faced any challenges giving a CPAP versus a baby, any other preterm within normal airways,
yes, sir,
or
which
no anomalies, no upper airway anomalies, a normal baby receiving CPAP and this baby receiving CPAP? What are the different challenges you have faced in this baby?
positioning was the main challenge, sir. Baby had to be resuscitated in a prone and lateral positions, and fixing this CPAP, nasal CPAP was difficult, sir. We tried Hudson and then we changed to Ram cannula, sir. And baby improved
Arjuna,
with
the whole idea is to learn from your experience, because many times it takes years, for many years, for the fellows to see such type of cases. So once you is it possible to give CPAP while the baby is in prone position? Can we
yes,
give CPAP when the baby is in the prone position?
yes, sir. We can give CPAP, sir.
Is it practically possible?
Sir, we did it, sir. Sir, firstly
Yes.
it was Hudson, but there was some difficulty, but because the baby was active and the baby was trying to remove all this, so we tried Ram's cannula and we could give good CPAP with Ram's cannula, sir.
What are the other challenges you have faced while giving CPAP? One is the position. So you have tried prone positioning and lateral positioning, and which is a where you can give CPAP in other babies also. You can give CPAP while the baby is in prone position or a lateral position. Not only in this particular case, but in other normal babies receiving CPAP also. What are the other specific challenges you faced which you don't face in other babies, in these babies, while you are trying to give CPAP in this baby?
Sir, by giving this to CPAP to preterm baby, this is a term baby, so baby was more struggling with this CPAP, sir. Baby was trying to remove this nasal prongs and also. And baby needed frequent suctioning also because of this swallowing difficulty. There was some pooling of secretions also. So frequent suctioning also was needed, sir.
See, the point I think Dr. Naveen wants to know is that because there is glossoptosis and the obstruction is beyond the point, where you're applying CPAP, so the CPAP may not get transmitted to the lungs. So that is, I think, important point. So there is a big challenge sometimes. So that
Sir,
is that what you want to
Yes, yes,
say? Doctor?
yes,
Yeah.
yes, correctly,
Correct, correct.
Tushar. That is one thing.
Yeah.
The second thing also, you can have a lot of leaks also from the oral leaks in the
Oral
CPAP. That is also another issue where many times you have to see from case to case that how you can provide a CPAP. And that is, yes, obviously the first step to do. And Archana, you were right that the term may bigger babies, they many times they fight and difficult to hold them in a CPAP position.
Yes, sir. Just to add one from our experience with this baby, just for the sake of the juniors who are here, that we might be tempted to actually intubate such a baby early because we are used to the supine position, and if the baby doesn't tolerate supine position due to glossoptosis, then you might be tempted to intubate. But we made an attempt to put in lateral and it did work. So if the baby has good spontaneous efforts and the baby is otherwise good heart rates and tone, then we could allow the baby to try CPAP for a little longer in different positions, which are of course expected to be difficult in terms of nursing. So training our nurses actually even in preterm babies to do CPAP in lateral and prone position will help the unit to gain experience to and confidence in doing CPAP in other positions other than the routine supine positions. Yes, and the other thing is that she said rightly that term babies are vigorous, so we had to do a lot of good nesting that she would kick away actually, but the nurses had to stand by and keep consoling the baby, so that was another challenge.
Correct. Dr. Archana, so I'll just take you a little back. Did this have polyhydramnios? I missed that part. Was polyhydramnios present there?
No, sir, liquor volume was normal, sir.
Normal. So suppose there was the polyhydramnios and you know that there is some anomaly where you may require some help in the delivery room. So when you're preparing, have you heard of exit procedure?
Yes, sir. Ex utero intrapartum procedures.
Yeah, so for the benefit of the fellows here, so in such a scenario, suppose there is polyhydramnios is there, and the chance of upper airway malformation needing support at the time of birth is there. So it can apply for a scenario like this where there is micrognathia and possible upper airway obstruction. So one could do ex-partum, intra-partum therapy. Do you want to explain in 2 minutes, 1 minute, Doctor?
Sir,
Dr.
yes, sir. Sir, start like a cesarean and head and upper part of the body is delivered, and while maintaining the plasma circulation under anesthesia, we do the procedure, sir. And also,
just to corroborate what she's saying, that the anesthesia in an exit procedure is a little different. They're usually done as a general anesthesia and a deep general anesthesia with enough precautions taken to ensure that the mother doesn't go into hypotension due to the deep general anesthesia. Because what happens when the baby is partially delivered is sometimes the uterus contracts, and if that happens, then the placental circulation is lost. So just having the cord intact and the baby half out, it does not mean that placental circulation is maintained. We might have to have the uterus completely relaxed. And that can be a challenge to the anesthetist who's taking care of the mother. So exit is half, head out and airway managed before placental circulation is discontinued.
Correct. So baby is connected to the mother through the placental circulation, and you do the procedure, secure the airway, and then clamp the cord, cut the cord, separate the baby. So you get some time after the baby's delivery of head and basically head and shoulder. As you deliver the baby is connected to the mother through the cord, and as Dr. Femita said, uterus should be relaxed for baby to continue to get blood flow. All right, we can continue.
so, next few slides I'll be presenting about Pierre-Robin sequence. It is characterized by the triad of micrognathia, that is small and symmetrically receded mandible, glossotosis, that is tongue that obstructs the posterior pharyngeal space, and resultant airway obstruction. In this picture we can see there is a small mandible, that is micrognathia, and glossoptosis, that the tongue is fallen backwards and there is airway obstruction. There can be associated cleft palate. In 90% of cases, it can be either U or V-shaped cleft palate. The second image, the tongue has this. There is a tongue that is posterior and it has fallen back, obstructing the airway. In this sagittal section, we can see that the airway is almost completely blocked by the glossoptosis. There can be variation in phenotype severity of micrognathia or glossoptosis. The first picture, there is a mild micrognathia, and the second picture, this micrognathia is severe. It is present, cleft palate is present in about 90% of cases. Whether the cleft palate is an obligatory feature of Perry-Robin sequence is debated. Previously, it was called as a Perry-Robin syndrome. Now it is called sequence because what is a sequence? Sequence is a pattern of deformations and malformations, which is a consequence of a single malformation. I'll be describing about the pathogenesis in later. The prevalence of this Perry-Robin is 1 in 8,500 to 1 in 20,000 live births. The triad of cleft palate, micrognathia, and airway obstruction was described in 1822 by Saint-Hilaire and in 1846 by Fairbairn. And Perry-Robin, a French stomatologist, first described and published data on glossotosis with relationship micrognathia and airway complications. This sequence is named after him. And he reported growth failure and death caused by the respiratory complications. What is the etiology of Perry-Robin sequence? Most of the cases, it is occurring as an isolated phenomenon. There can be associated syndromes also. And in more than half of the infants, associated syndromes, chromosomal anomaly, additional anomalies, or other medical concerns will be there. In such cases, the baby will be sicker. More than 40 syndromes with Robin sequence have been described. The most common ones are Stickler syndrome in around 47% of cases and 22q11 deletion, that is velocardiofacial syndrome. This is a picture depicting the clinical features of this Stickler syndrome. It is a autosomal dominant disorder with abnormal collagen. There can be features of Perry-Robins with U-shaped cleft palate and progressive sensory neural hearing loss, severe progressive myopia, that is short-sightedness. Normally, newborns will be having hypermetropia. So, if we see a baby with Perry-Robin features and myopia, it is suspicious of Stickler syndrome. Can also have other features like flattened facial appearance, hypermobility of joints, cardiac malformations like mitral valve prolapse, congenitally enlarged wrist, knee or ankles, epiphyseal dysplasia, retinal detachment or vitreal degeneration also. These are some of the conditions associated with the Perry-Robins. Most common are Stickler syndrome and velocardiofacial syndrome. Coming to the pathophysiology part, the mandibular development occurs at around 6 to 11 weeks of intrauterine life, and it's 9 to 11 weeks of embryonic development. Mandibular hypoplasia occurs. This mandible and tongue develops together. So if there is mandibular hypoplasia, there will be posterior displacement of the tongue. Because there won't be space for a tongue to develop. So tongue will be posterior and upper position than normal. It prevents the palatal shells from growing together. It prevents the palatal shells from fusion because it was blocked by the developing tongue. So U-shaped cleft palate is occurring. Here, hypoplastic mandible, it is a primary anomaly which leads to glossoptosis. It's a secondary anomaly, and the tongue obstructs palatal fusion and U-shaped cleft palate. How to diagnose it prenatally? Prenatal diagnosis is challenging. Only if your reports of prenatal diagnosis are there. This ultrasound identification of micrognathia is mostly subjective. It is diagnosed with the prominent upper lip and small chin in the facial profile. And on 2D ultrasound, it is often missed. And retrognathia is a normal finding in the early gestation. Mandible may undergo significant growth after 20 weeks of gestation and after birth. So diagnosing retrognathia and micrognathia is difficult, but some methods are there for prenatal diagnosis. These two angles are described. One is inferior frontal angle. The other one is frontonasomental angle. In this inferior frontal angle, here in this sagittal section in midline, a line is drawn parallel to this forehead, and perpendicular to this another line is drawn at the this nasal bone, and another line that connects the chin and upper lip is drawn. The first picture is that of a normal baby. This is inferior frontal angle. If this second one is that of a peri-Robin baby, here the angle is less. If the angle is less than 49 degree or less than 2 standard deviation, it is suspicious of micronathia. And the second angle, frontonasal-mental angle, from frontal bone to nose and to mentum. If the angle is less than 142 degree, it is suggestive of this micronathia. Re-evaluating the fetal mandible in the third trimester more accurately demonstrates mandibular size and form. There are mandibular growth charts available, where the also the fetal mandible size can be compared related to the biparator diameter. This method is more sensitive and specific mode for identifying micronathia. The fetal mandible size compared related to this BPD. 3D ultrasound may improve visualization of facial morphology and micronathia. Another method is fetal MRI. Coming to the mechanism of airway obstruction. The displacement of tongue to the hypopharynx, occluding the airway at the level of epiglottis. This size of the oral cavity will be reduced due to this microryptonathia, but the tongue size will be normal. So there will be disproportionate tongue growth. The tongue prolapse into the cleft palate. This is another mechanism. Tongue may be sucked into the cleft palate, can also cause the upper airway obstruction. And the tongue musculature, tone of tongue musculature may also be less. And airway obstruction of infants with the Robin sequence commonly improves with time. In most of the babies by 1 year of age, this mandible shows a catch-up growth, and this obstruction is improved. By by around 5 to 6 years of age, most of the babies will have a normal sized mandible, and the glossoptosis will improve with the growth and neurological development. So when we get a baby with this peri-Robin sequence, we have to evaluate the airway carefully. We have to understand the site of obstruction in Robin sequence. It is the critical steps for determining optimal therapy. Because there may be obstruction at multiple levels. So we have to identify the level of airway obstruction in Robin sequence. Through endoscopic airway evaluation, we can determine the level of airway obstruction. It will guide in the management also. Upper airway and vocal cord mobility can be assessed by bedside laryngoscopy, and subglottic area direct laryngoscopy if possible. We can perform jaw thrust maneuver under anesthesia and look whether the mandibular advancement can ensure dynamic airway change. So when we are managing a baby with the peri-Robin sequence, we have to mainly address two things. One is upper airway obstruction, the other one is feeding issues. What will happen if this baby is untreated? There will be airway obstruction, asphyxia, hypoxic respiratory failure, and cor pulmonale. And there can be feeding difficulty leading to malnutrition and death. How to manage this difficult airway? As we managed in our baby, the first step in management is prone positioning. This prone position allows mandible and tongue to fall forward and reduce the airway obstruction at the tongue base level. Positioning alone is successful in at least half of the babies. And we have to monitor. Ongoing monitoring of breathing, feeding, and growth are critical in managing. And significant airway obstruction may present after the newborn period. It may present in the second month of life also. So we have to follow up these babies frequently. And airway obstruction can occur spontaneously or with feeding or at sleep. First step was positioning. Next one is nasopharyngeal airway. When prone positioning alone fails, we can try this nasopharyngeal airway. This nasopharyngeal airway helps in relieving the obstruction posteriorly because it breaks the seal between the tongue and posterior pharynx. the child can breathe through the tube and the contralateral nostril. We can discharge the baby safely with the nasopharyngeal airway in place, and we have to teach the family how to take care of this nasopharyngeal airway. If these two methods fail, we may have to opt surgical therapies. There are mainly two types of surgical treatments for this Pierre-Robin sequence. One is tongue lip addition. The other one is mandibular distraction osteogenesis. Let's come to tongue lip addition. Here, what we do is anterior ventral tongue is attached to the sutures to the lower lip, and the posterior tongue is anchored to the mandible. This procedure, the problem with this procedure is that this procedure restricts the tongue movements, and it may cause dehiscence and need for subsequent procedures. Since the tongue mobility is altered, it can cause swallowing difficulty also. This is a picture showing this tongue lip addition. Here the ventral tongue is sutured to this lower lip and posteriorly anchored to the mandible. Another procedure is mandibular distraction osteogenesis. This is done for patients with airway obstruction at the tongue base. This method, it increases the mandibular size and increases the pharyngeal airway size by gradual mandibular lengthening. Here what we do is, we do bilateral osteotomies of the mandible and placement of distraction devices. Devices can be either internal or external with the help of percutaneous pins. External ones are easy to adjust and remove, but the adverse effect are dislodgement of the pins or scarring. Internal devices are better tolerated, but this requires repeated dissection for removal under GA. In this picture, this mandibular distraction osteogenesis is performed. Here first, this mandible is divided, and then distraction and gradual lengthening of the mandible. In this picture, the first picture, in this baby, they did mandibular distraction osteogenesis, and this was the resultant picture. There are 3 phases following osteotomy. In the first phase, latent period, that is for the early osteotomy healing. Then activation phase, where the device opens the osteotomy at a rate of 1 to 2 millimeter per day as the mandible, suprahyoid muscles and tongue are brought forward. And the third phase is consolidation. First phase is latency, then activation, then consolidation. And the third phase, ossification of the distracted gap with the device in place. But in some cases, around 5% of cases, these 2 methods also fail. They may have to undergo tracheostomy later. This is the definitive procedure for airway management for children with upper airway obstruction. This is done when it failed to respond to other measures. And for multi-level airway obstruction, for airway obstruction other than this upper airway, if there is some other obstructions also, tracheostomy may be needed. Also, when in chronic ventilator dependent babies also, tracheostomy may be needed. So summarizing the management part, first step is positioning the nasopharyngeal airway, intubation if it is needed, and surgical methods are tongue lip addition and mandibular distraction osteogenesis. In some cases, tracheostomy may be needed. So after we relieve the airway obstruction, we have the other step in managing this baby with Pierre-Robin is attention to feeding and growth. The airway obstruction can cause difficulty in feeding, swallowing dysfunction. The associated cleft lip can cause aspiration, and GER may affect oral feeding. The problem is worse if it is associated with any underlying syndromes. Since this baby have respiratory distress, nutrition and energy expenditure will be more. And swallowing will be difficult, so there may be difficulty in initiating oral feeds, and nasal or orogastric feeding may be needed initially. And we did our baby, we initially started on OG feeds, and we tried special feeding bottles since breastfeeding was difficult for this baby. If there is isolated peri-Robin sequence, feeding issues rarely extend beyond 1 year of age. The occurrence of GERD has been described in babies with the peri-Robin sequence. This GERD can cause airway inflammation and edema, and further aggravating the already blocked airway and feeding difficulty. Embryonic reflex treatment may improve both breathing and feeding. So therapeutic intervention will be decreasing the feeding duration and increasing calorie intake, oral motor stimulation, positioning of the baby, and specialized feeding bottles, nasogastric tubes, gastrostomy tubes placement when the baby cannot tolerate orally, and maintaining adequate respiratory stability during the feeding is a priority. Here, this is a special feeding bottle, that is Haberman bottle. We are feeding our baby with Haberman bottle and OG feeds also. This is an assisted feeding bottle, and it is activated by tongue and gum pressure rather than by sucking. It has a long teeth, slit valve, which controls the flow of feed depending on the orientation within the baby's mouth. It has 3 markings to regulate the flow. If the longest mark is positioned towards the baby's nose, the flow will be more. And if the short one is positioned, the flow will be less. And it has a reservoir, a collar, a disc, and a valve membrane also will be there. After discharging these babies with peri-Robin sequence, we have to monitor their growth, development, speech, orthodontic care, and we have to look for obstructive sleep apnea also. Multidisciplinary treatment is the key in managing these babies. So in this slide, when we admit a baby with Robin sequence in NICU, we have to evaluate the baby to rule out any associated syndromes, and relevant consultations like plastic surgery, ENT, speech, pathologist, genetics, and ophthalmology evaluation will be done. We did it for our baby. We did plastic surgery, genetics, and ophthalmology and cardiology evaluation for our baby. Ophthalmology evaluation is mainly to rule out stickler. And if the for our baby with nasopharyngeal airway, baby remains stable, so we did not do further airway evaluation because we did not suspect any obstruction other than this upper airway. If obstruction is not getting relieved in some babies, we may have to do bedside flexible nasolaryngoscopy, swallowing evaluation for GERD, and CT scan of head or face for any craniofacial anomalies, sleep study, and for any comorbidities, neurologic or syndrome. Managed with prone or lateral position, reflex therapy, consider PICC line for difficulty in feeding, and immediate or date for direct laryngoscopy and bronchoscopy for sicker babies. So if the sequence is mild, prone positioning and nasopharyngeal airway. If it is moderate to severe with the apnea hypopnea index is more than 6 and prone positioning alone fails, we may have to do this tongue lip addition or mandibular distraction osteogenesis. And in severe cases which fail to this prone position and NPA and multi-level obstruction, and with apnea hypopnea index is more than 6 or central apnea is associated, we may have to do this tracheostomy. This slide summarizing the management plan for peri-Robin sequence. First, we have to do feeding evaluation and nutrition evaluation, and consider NG feed initially, and adding more calorie to feeding by fortifying the feeds. Address the feeding issue. We do a solo evaluation, that is a fluoroscopic evaluation, and GR evaluation in babies with poor weight gain, and GR precautions, and we may have to consider PEG feeding. Other evaluation to rule out other airway disease, prone positioning, and flexible laryngoscopy or bronchoscopy for persistent airway obstruction, and nasopharyngeal airway, mandibular distraction, or tongue lip addition, or tracheostomy depending upon the baby's clinical condition.
So she has a part on the management of a neonatal airway also, if the discussion needs to go on, sir. Otherwise, we can have questions from you.
Archana, you have presented very well, I think, covered much more than the normal neonatology books have written on this airway obstruction. But possibly what we will discuss is the practical points. And I'd like to ask you, what are the common practical complication in such babies which we should anticipate?
Sir, while in the hospital, we may have to address the airway patency and
The complication that is that is okay. We have such difficult airways, maybe of pyropen or any other syndrome.
yes, sir.
So
Other
in
than
babies which have abnormal upper airways, what are the common complications which we encounter?
sir, this baby has a cleft palate also. A chance of aspiration is there. And like what happened to our baby, a minor upper respiratory infection or common cold can cause severe problems in babies.
So you have more incidence of aspiration as well as the respiratory infections. Yes. Yeah,
Sir,
that is one part.
Sir, oral feeding may be difficult, sir, because
So
of this
growth.
airway obstruction. And
So first we will deal with the respiratory part. So you have more of a respiratory infections, aspirations. Anything else in the respiration part?
Sir, this
Because of the respiratory pathophysiology,
there can be apnea, sir.
there can be apnea. Yes, there can be more incidence of pulmonary hypertension also in such babies.
For pulmonary can
So
also
you need to monitor their pulmonary pressures clinically, or if required, then by echocardiography. And then you have a nutritional challenges of
yes, sir.
growth failure.
Nutrition demand will be more, sir, because of this increased work of breathing. So and increasing giving this oral feeding may also be difficult because of the swallowing difficulty and associated comorbidities like this cleft.
Yeah, that you have already described in detail.
Can these babies because can these babies really breastfeed, or breastfeeding is impossible in these babies?
Sir, if depending upon the severity of the illness, sir, we can try breastfeeding. This our baby, we attempted breastfeeding. Baby was sucking with some difficulty, but baby was not able to get much milk because of this nasopharyngeal airway itself caused a difficulty in latching and feeding, sir. And baby could tolerate this bottle feed, sir.
Yes, it is.
Any particular technique or method you will recommend in such scenario?
Sir, holding either we can try football holding position or feeding in the upright posture, sir.
The answer hold position. Yeah.
Yes, so that point is to be taken by all the students that a cleft palate is not at all a contraindication for direct breastfeeding, and it should be attempted if otherwise the baby is neurologically good.
Archana, if you have to give every one of us a few take-home messages, like I'll say 8 to 10 take-home points only, then what would you like to say at the end of the discussion?
Sir, when
We'll start from zero.
Sir, sir, being
You have already described it. Let's just sum up and give some take-home messages.
sir,
Practical, not theoretical.
we are practicing neonatology, so we may expect this kind of babies with difficult airway. If we diagnose it antenatally, we can plan accordingly. With our team can be prepared. We have to take all the necessary airway equipments with us. And before that, we have to do antenatal counseling also, address the parents or caregivers and tell them what are complications we anticipate. And when the baby is born, we can address the condition with, we can do resuscitation with this
So special preparation at
Yes,
the time
sir.
of attending delivery, which includes
Which includes
oral
this
airways, nasal airways,
LMAs,
LMAs specific if you and you expect
laryngoscope.
a difficult intubation, and if you have a video laryngoscopy, then yes, and a expert in intubation.
Yes, sir.
Okay.
And
The baby comes to NICU.
baby comes to NICU. If there is glossoptosis, we can try positioning, prone positioning, sir. And if the airway is not maintaining, we can try other methods, sir, like this nasopharyngeal airway. And we have to take care of this feeding also, sir.
So positioning very important, and then comes a maintaining airways or initiation of non-invasive ventilation, whether it is a form of CPAP or maybe NIV also.
Yes, sir. When we are
And
discharged,
intubation is going to be your last resort. Okay.
yes, sir. And this feeding part also, sir. Difficulty in oral feeding, we can try this nasogastric feeding. And if the baby is not tolerating oral feeds, this PEG feeding, gastrostomy feeding can be attempted. And we can discharge baby home safely with this PEG feed and this nasopharyngeal airway. We have to train them how to take care of this nasopharyngeal airway at home. We'll have to counsel them how to come for this follow-up. We have to follow up periodically and
nutritional management, which includes feeding. We anticipate difficult feeding, so tube feeding, high energy feeding because of high caloric demands, and then if possible, we will go for a special bottle feeding and breastfeeding. And if we are having GR, then treat it.
yes, sir.
Sir, just to know your experience, sir, do you actively treat GER in many of these babies' situations with difficult airways, sir, or do you restrict the number of drugs used? Like many of the surgeons we ask, may
We
ask.
do, yeah. We will proactively treat because many of these babies will have some amount of GR, and that will again increase the breathing difficulties and the other issues. So most of these babies will have some amount of reflux.
So by chance, we are having this kind of baby in our unit right now. And yes, that baby also had here, but yes, we try to avoid giving H2 blockers. And that baby is on GR treatment, on domperidone, but not on H2 blocker. So depending upon the severity, probably you can decide whether you are going to give H2 blockers or pantoprazole or not. So point for take home message: prevent complications. Correct. So which complications important ones? Aspirations, you told,
Yes, sir. Apnea.
respiratory infections, and
Croak.
pulmonary hypertension.
Yes.
Then comes the specific therapies, which you have already depicted quite in details, and that goes to the specific therapies individualized for each and every baby, depending upon the case to case and which sort of airway obstruction we are dealing with. And what about endoscopies?
Sir, if multi-level airway obstruction is suspected, we can do this.
You're not about the theoretical part. So, practically, how many of the units have access to such a small endoscope? Uh,
Sir, video laryngoscope we do quite commonly.
yeah, I don't know. Honestly speaking, my unit do not have access to such a small bronchoscope. I mean, to endoscope, I mean to say is the bronchoscope.
Bronchoscope has smallest is 1.8, sir, but they don't like to put
The
it.
smallest means, yes, some smallest, yes, they are available in Western countries, but how many of neonatal units in India have access to that procedure, neonatal units? Probably a multi-specialty at tertiary level hospital which have the facilities for a good ENT or backups or the pulmonary backups. they might, some of them is having, and if you have, then yes, you can take advantage of that. And this looks like a quite a beautiful article, neonatal laryngeal disorder, 12-year experience. I think we will all would like to have just abstract of this, if you can describe it in 2-3 minutes of your experience. Yeah.
Actually, next slide.
Archana?
So this was at least 3 or 4 years back published in the article, the journal called Airways. That's the official journal of the Indian Association of Anesthesiology. So these were purely descriptive article. So we had done 90 consultations to laryngology. That's how we retrieved the data. And most of the indications for the consult was noisy breathing. Then there were some which were done when we did not find a clear-cut respiratory cause, as in a lung cause for a respiratory distress. And then other reasons also, some of them including Brui-like events who came recurrently with apparent life-threatening events. So the findings were, these were the findings we
Sorry,
got.
Kavita, these are only for neonatal, these were, or that included pediatrics
Neonatal.
consultation also?
Only neonatal, sir. Our unit alone, the newborn ICU.
Okay.
No, some of them turned out normal, sir. And those were mostly the babies who were done for respiratory distress unexplained, or for preterms who were on prolonged ventilation when we thought that the cause is probably airway related. But finally, the laryngoscopy turned out to be normal. So it would have been BPD mostly. But the common finding as such was laryngomalacia. In that also, sir, we had to do intervention only for 5 of them totally. If you see the third column, sir. Array epiglotoplasty for 2 of them and tracheostomy for 3 because it was very severe. Out of that 3 tracheostomies, 1 was because the array epiglotoplasty failed, as in the baby didn't improve. VC palsy is quite, it's not uncommon, sir. We find it idiopathic and bilateral. So in those cases, we did tracheostomy for 5 of them, and all 5, I think, so 1 was dependent and the other were decannulated. Peary-Robin sequence, we had more number of Peary-Robin sequence than the ones which required laryngology evaluation. So this is just a very pure descriptive article, but a description of 90 cases, sir.
T, please contact 1987. Dr. Akhil T, please contact 1987.
Sorry, sir, it's the overhead.
Yeah,
Yes,
no issues. So it is interesting to note this one, columns of glottic stenosis in BPD babies, where you have tracheostomy for 2 babies.
Yes, sir. But
What is the average day of tracheostomy here?
Sir, that's what the number of BPDs are much huge, very much huger than the babies who finally required. So in the span of 12 years, we had to do tracheostomy for 2 babies, sir, for BPD alone.
Yeah, I just asking 2 babies at what postnatal age? That was
3-4 months of age. And they didn't do well, sir, actually. As in they were dependent on the tracheostomy even at 2 years, those 2 babies. So this was more than 100 plus days of ventilation, sir. Invasive ventilation. So it's a little long time ago that.
okay, quite interesting and very useful data. This is.
Thank you, sir.
Yeah, Tushar?
Yeah, so yeah, it's very so 15%, 16% will have vocal cord palsy also. So I think, I suppose, it's bilateral vocal cord palsy.
Yes, sir.
Right.
Yes, sir. All the 16 were not bilateral, sir. I believe the
Okay.
5 was bilateral.
Right. So yeah, I think airway is challenging, especially in a scenario when you are not able to intervene the ENT backup support and the scopes are not there. So it is challenging. So ultimately, what is the how's this case doing? The nasopharyngeal airway is still there, or what is happening to this particular baby?
Yes, sir. The baby has a resolving respiratory infection with nasopharyngeal airway in situ, and we are trying to increase the volume of oral feed, sir. Baby is tolerating about 40 to 50 ml of bottle feeding also, sir. Rest we are giving through OG2. And when the baby is able to tolerate full oral feeds, we will room shift the baby and discharge later, sir.
And the nasopharyngeal airway?
Sir, now as of now the baby needs nasopharyngeal airway, but the requirement is less compared to the initial days, sir.
And just for everyone, how do you take care of the nasopharyngeal airway?
Sir, this baby needs frequent suctioning because one problem is because of this airway irritation, there will be increased secretions for this baby. Associated respiratory infections made this worse. So the baby needs frequent suctioning also, sir.
And a replacement, like once you place it like that for a long time, or do you replace
Sir,
it
we
after?
alternate the no, sir. Every weekly we do this.
Yeah. All right. So I think it's a good presentation and a good case, and I think you covered a lot of topics right from fetal part and later on also, and therapy and this particular article. As far as I mean, these are all fellows who are appearing for the exams. Just one point which I thought I think is important, that when you are presenting a particular case, like say this case is there, so things which are relevant to this case, like so those things should come up when you're doing general examination or systemic examination. Say for example, in this particular case, you talk about like no other dysmorphism which are there, or pulses are equal in all the limbs. That is so. Blood pressure, I mean, okay, I mean, is there. And then if the distress is there, I think you did mention about Downey score, I think, but yeah, I mean, the in general examination, the level of support and the amount of distress, whether that is there. So specific pertaining to this case, and even the cardiac examination, the systemic examination pertaining to this. So if that happens, that you are keeping that particular baby in mind, and the examiner doesn't have to ask you too many questions because you already told those things. And then the viva will go on management part and newer therapies, and once that starts, then probably you already know that you're through, and you're scoring. Once they go for management and higher therapies and all those things, it means that you're already through. But if they start asking you very basic questions, then probably the history, the negative history, and the clinical examination itself should tell the examiner that you already thought about those other possibilities. So this is just for everyone for this thing. But I think overall, I think your presentation was very good, and including the literature review. Dr. Naveen. Yeah.
Yeah, correctly pointed out, Dr. Tushar. And I think we have spent enough time, 1 hour and 12 minutes nearly. Famita, if you allow, do you want to close the session?
Okay, sir. Thank you very much, sir. Naveen sir, Tushar sir. It's very
I think
valuable.
you have already addressed most of the questions which were there in the chat box, and many of them got addressed by the presentation itself in the later part.
So then shall we close, sir? Very
Yeah.
much time. Good
Yeah,
night.
thank you, Archana. Thank you, Famita.
Thank you,
Thank
sir.
you. Thank you, everyone. Good
See you,
night.
Tushar. See you soon.
See you soon. Good night, everyone. Yeah.
Sooner than you expect.
I hope so.
Okay.
Bye.
Bye, sir.
Yeah.